Good evening, everyone. We are going to get started with our um, bi weekly CCS exam prep course. And we have a lot of things to do on this evening. So let me set the stage and really talk about where we've been and where we've headed. So last week, Wednesday to be exact, you had an exam that was about, I think it was like 87 multiple choice questions, 87, 89, something like that, right? And so my agenda item for today is to review every question that was missed on the exam. And I'm doing this not to make anyone feel bad, but I want to ensure you walk away tonight with a different mindset than you started with. Speaking of started, I was looking at the calendar and I said, ooh, today is March 17th, 2025. We started this journey January, let me just look at my calendar, but I believe it was January 27th. Yeah, because that's a Monday. And so there were several things that I asked you all to do, one of which was to print a copy of the ICD-10-CM guidelines, read them, understand them, comprehend them so that you can apply them. So that was something I asked you to do very early on. And this exam, which was your third exam, was very telling from the perspective of I wonder, and I'm not sitting there with you, I'm in Chicago, but I'm wondering, did you in fact, A, print the guidelines, and B, have you actually been reading through them? Now, I'll be the first to admit, it takes a while for the guidelines to sink in, but during the CCS exam, just like this exam, you have the guidelines in front of you. But just like the CCS exam, you had one question at a time, which means you focus on that one question before you move to the next. But what I'm wondering, and this is a question among many questions that I'm going to ask you to reflect on tonight, is if you read the guidelines, if you understand the guidelines, could you in fact apply them on the day of your CCS exam and last week? So I'm going to talk more about that, but I want to really be very intentional about how we proceed. I think I mentioned to you all before that I used to teach coding. I don't really teach it that much, that often. Many students that have had me in the past have said that I was extremely tough on them when I was teaching coding. And that's because I love coding and I want everyone else to walk away with what you came here for. So you came to this review class because you want to be a CCS. And what you do with all the information that I give you is really truly up to you. So I wanted to take a moment and really talk about mindset. And then I'm going to get into the review of the exams. And I think you're going to like this review. It took me, I would say, probably about 6 hours to put this review together for you because it took you 3 hours to do your exam. It took me 6 hours to put together this review, and then here another 3 hours for me to go over this exam with you. And I want you to remember where we are today, March 17, 2025. We haven't even gotten into ICD-10 PCS. We have started a little bit with inpatient coding the record. And then we spent a significant amount of time doing the scenarios that we've been doing, right? And so, as you're doing each step of this process, it is my desire for your mindset to change so that you can be successful on the exam. So, it doesn't matter what exam you are taking, you just happen to be preparing for the CCS exam. Your mindset is everything. And so, I want to offer these 10 tips, if you will. So, number one, you have to be clear about what your goal is for this review class. If your goal is not to take the CCS and you just want to hang out and review, that's fine with me, but that's your personal choice. But if it is your goal to successfully pass the CCS exam, you have to ask yourself, what am I doing to get there? I think there's this misconception of, oh, I take a review class and I'm going to be ready for the exam. And honestly, a review is just that. It is a review. Reviews are not designed to teach you a full-blown coding program. So you have to be, and I hate to use this word again, but you have to be intentional about the notes that you take, your strategy. So let's talk about strategy, study plan. We get together on Monday and Wednesday evenings from 6 to 9 Eastern Time, 5 to 8 Central Time. And if you are only studying on Mondays and Wednesdays from 6 to 9 Eastern Time, you're setting yourself up for failure. And I hate to use such a harsh word, but I want to be realistic. I want to be intentional about about where you need to be and where you are. Outside of the Monday, Wednesday situation, you should be reading your guidelines. I've mentioned multiple times that I think many of you would benefit from a basic coding textbook, going back to the basics, because in this review, I can't teach you how to code. Now, you may learn a lot of things along the way, but this is not a class where I'm teaching you how to code. We're reviewing for the exam. So you have to think about, how am I going to attack the other days of the week? I know many of you are working during the day, and so you're like, I'm tired when I get home and I got this Monday and Wednesday situation. My question to you is, how bad do you want it? Number 3, it is so important that you understand the exam structure. You have at your fingertips on the AHIMA website what you need to know to prepare for this exam. But that content is literally the floor of what you need to know and not the ceiling. And I use that statement with you multiple times, but um, I'm going to give an example of what I mean by that so that you can walk away with it today from a different perspective. So really truly understanding the exam. We talked about before that the exam is testing your knowledge of, or the questions are written, I should say, from the perspective of three cognitive skills: your ability to recall information, your ability to analyze information, your ability to apply information. And so, one of the things that I am wondering when you're looking at the question, is your brain operating in that mindset? Okay, so the AHIMA website has everything you need to know about the exam. You just got to read it. Number four, using reliable resources. So tonight, as I do this review of all questions that were missed on the exam, I am going to show you what are considered to be some reliable resources. Number five, practice on a regular basis. Yes, Mondays and Wednesdays, and we haven't done this in a couple of sessions. We've been practicing different scenarios. I put the scenario up on the screen, you code it, but what are you doing outside of that? Number six, join study groups or forums. I know some of you may not be on the Facebook, but there are several study groups that are available that have lots of really cool resources. You want to make sure that they're reliable resources. And the other thing is, it's free to join those groups. Other than a basic coding textbook, I wouldn't buy anything else, because when you are trying to study for an exam, and I've taken 14 national exams, whew, having too much information makes you just kind of like do nothing. Okay. So I would recommend checking out a Facebook group. If nothing else, people who are also going down the journey with you, outside of the folks that are in this review. It could be a place that you can hang out after this review is over, right? All right, number seven, stay positive and manage stress. Life be lifing. I totally get that. And it's easy for things to derail you, to distract you. But you must stay positive during this journey. And you just have to keep telling yourself, I will pass the CCS exam. I will pass the CCS exam. It was like yesterday, my best friend and I were taking the medical assistant exam. And I remember her saying, I'm not retaking this exam. I'm only going to take this exam once. But guess what we did? We studied. And we didn't just study a bunch of multiple choice questions. We studied the concepts so that we could recall the information, apply the concepts, analyze a scenario, do all three at one time, because we wanted it bad. It was like our life depended on it. Managing stress. Everybody does something different to manage their stress. You literally have to decide what is going to be your thing. I use so many things to manage stress: reading, exercising, laughing, listening to music, just so many different things that don't cost me anything to do them, but are really important to my own mental health. Number eight, review and revise. Your study plan today may not be what your study plan looks like 30 days from now. It's okay. Continue to review your plan. Know that old saying, if you fail to plan, you plan to fail. So review whatever it is your plan is and make sure it still works for you, because things change. Number nine, stay updated on the AHIMA website. It's March 17th, 2025. AHIMA is going to change that exam May 1st, 2025, which will be um just a few weeks before our journey together is over. And so you just want to stay abreast of any changes that they may post, because I see on forums all the time people asking questions about the exam, and people are throwing out answers, and sometimes those answers are wrong. I'm like, whoa, know the information for yourself. Last and certainly not least, believe in yourself. If this is something that you want to do in your heart, you have to believe in yourself. Now, if I could be honest with you guys, and I know I can be honest with you because we've been hanging out for a few weeks now, all of you, with the exception, I think, two of you, are currently working at hospitals as coders. Now, two of you are working as inpatient coders, the rest of you are doing outpatient. But you're blessed to have a coding job, because there are many new graduate coders who have passed their tests and can't find a job. So you're blessed in so many ways because of what opportunities have been provided to you, like this review class that was provided to you. But believe that you can do this and continue to tell yourself it every single day. All right. Well, it is now time for our post exam review, which really focused on ICD-10-CM guidelines. Yes, there were a few coding exercises on there, and where you had to actually assign the codes. And that was telling as well, because many of the questions were about guidelines, right? But then some were where you had to actually assign the number. And this is something that really became evident to me. If you don't know the rules and can't apply the rules, you're going to get the question wrong. And if I could be honest with you, when I took the CCS exam in 2006, at that point, I had not done any inpatient coding. So I started in 92 as a medical assistant, got basically forced into medical records and coding and billing and all the things, right? And 2006 was when I had taken a job that required me to go into the DRG world. And so I was like, oh, if I'm gonna talk the talk and walk the walk, I need to have that certification. And what really helped me pass that exam with no inpatient coding experience were the guidelines. Hands down, I knew those guidelines. And so it is my goal today that you walk away with, number one, lots of notes, but that your mindset shifts as a part of what you're going to experience tonight. And I know many of you have already said that, the different weeks have been very impactful. And I notice up here I say it's March 12th, but it's not March 12th. It's March. It's March 17th. Oh well, not going to change that now. It's March 17th. But many of you have talked about how impactful the Monday Wednesday reviews have been thus far, but we're not done. We are like warmed up. So we are starting on Wednesday, are going to get into the reviews of the different domains. And I know some of you are wondering, hey, when are we going to get into back to those scenarios we've been coding? We're going to get back to those, but it's March 17th. We started January 27th. I have to make sure that I do the review, right? Not have an introduction to coding codathon, right? So I wanted to display this on the screen tonight, because some of the questions on the exam tied directly to these domains. In particular, assign diagnoses codes based on the provider's documentation in the health record. Now, I provided you with some health records last week, and we are definitely going to be talking about that first case tonight, as long as we don't run out of time. But we haven't started procedure codes yet. Okay. But you need to be able to assign the codes based on what is documented, not what you do at work, what is documented in the health record. Number two, identify the principal first listed. Principal is for inpatient, first listed is for outpatient, based on guidelines. Number three, apply coding conventions and guidelines and regulatory guidelines. The questions that you had on your last several exams, you only had three, were testing your knowledge definitely of one, two, and three. We haven't gotten to four yet, so I'm going to skip to five. Determine the appropriate sequencing of diagnoses and procedure codes based on the scenario. And again, we haven't done procedures, but you were required to do a little sequencing. Okay. Um, we have not started POA guidelines, but let me just give you a serve notice. If you have not read the POA guidelines, you need to get on it, because that will be making an appearance in one of these review sessions. Okay. Identify, I'm skipping down to no, number 8. Demonstrate knowledge of reimbursement methodologies, DRG, APCs. APCs is for outpatient hospital, DRGs is outpatient. We talked about DRGs because we looked at the inpatient record. And so I'm going to share additional resources that I think you need to be familiar with for this exam. Let's see. Identify major comorbid conditions, major comorbid conditions, and then comorbid conditions. Now, let me just pause right here and say something. And this is not meant to be, I don't want to use, not to be disrespectful, not to be condescending. Um, I'm going to tell you about me. Whenever I'm reading something, if I don't know what the word means, I look it up. So as you look at this domain number 1, if you don't know what any of these words are as it relates to healthcare and medical coding, do yourself a favor and look them up. So very important. Doesn't matter whether it's medical words, English words, look them up. All right. Domain number 4 is on regulatory compliance. And I'm going to skip down to number 6. Ensure compliance with the hospital discharge data set. Okay, guys, here is the dealio. In the guidelines, I asked you to read the guidelines starting January 27th, when I mentioned about printing them and having them spiral bound at Office Max, Staples, whoever you use for printing needs. Well, in the section 2 of the guidelines, which focus on principal diagnoses, they mention the word uniform hospital discharge data set. And so, again, anything you're reading, and guys, if you could see my home library, I read a lot, and I read medical books and non-medical books. But if I had to quantify what I read today, 2025, after being in healthcare for 33 years, I read 5% medical, 95% non-medical, because I'm trying to expand my brain like never before. Because I've learned that a lot of things you need to know in life are in books. So we'll talk a little bit about the UHDDS tonight. So the UHDDS was developed in, and we'll talk about this as a part of the review, but it was developed a long time ago. I don't even remember the date. But the UHDDS requires that when we are submitting claims on the UB04 claim form, it requires that we capture certain data elements. These are the data elements that we have to capture. And so you see principal diagnoses, other diagnoses, right? You see those things listed there. But look all the way down towards the bottom. Disposition of the patient, also known as discharge status. Remember, we talked about that last week? Guys, if you aren't taking proper notes, if you're missing things when we're in class, here's something else I recommend. You have the recording. You're taking notes during the live portion of the course. I recommend you go back, listen to the recording, and really see, like, okay, what am I missing? What are my notes missing, if you will? Okay. All right. So that's enough about that. And I really want you to remember, you are taking the CCS exam, which requires you to code hospital inpatient. It requires you to code hospital outpatient. And so, because 99% of you code outpatient already, you really need to be intentional about developing your inpatient coder brain. Okay. All right. So, and what I exactly mean by that is, as you're coding scenarios on the CCS exam, some are going to be outpatient hospital. You got to put your outpatient coder brain on. Some of them are going to be inpatient. You got to put your inpatient coder brain on. If you're not coding today at all, you really need to be strengthening your coding muscle by a basic coding textbook, reviewing the basic steps of coding. I've given you guidance on those books before, so I'm not going to even go into that again. But just keep in mind, I want you to really think about developing your inpatient coder brain. All right. So, look familiar, guys? Does this page look familiar? It should look familiar because we've talked about these guidelines so much. And let me just say this. Guys, you cannot it's probably not feasible for you to memorize the guidelines at this point, but you have to build your knowledge of the fact that they exist so that on the day of the exam, you can go to the page that you need to go to, having already read and understand that guideline, so that you can apply it for the day of the exam. And so, my goal, and I don't know if you notice this, my strategy is, I'm really trying to get you to a place where on the day of the exam, you've built up your stamina. And so that 4 hours won't phase you. You will go in there and you'll know how to operate in a 4 hour exam situation. All right, because of the amount of information that I'm going to be covering today, we are going to take lots of, I'm going to call them small 10-minute breaks. So let's get started with the first one now. And I will play a little music. All right, that was our quick 10-minute break. And so let's get ready to dig into the questions. So I was looking on the break, you had 89 multiple choice questions. They were displayed on the screen one at a time. You were supposed to use your guidelines. If you had a printed copy in front of you, that probably made life so much sweeter because you would have been able to just flip from one page to the next. Or if you had them on your iPad, you were able to do the same thing. All right, so let's get into the first question. So this question, I like to call this a freebie. And what you're going to find on national exams is that some of the questions are going to be like, oh my gosh, so they're going to be so like easy to answer. Um and others won't be. But guys, when the questions are coming directly from the guidelines verbatim, there is no reason to get codes wrong. Now, I know you probably said, well, that's easy for you to say, no reason. I want you to think about your own reason. When you took this exam last week, and after you see the questions that you got wrong, ask yourself, did you click the wrong thing? Were you overthinking it? Figure out what your thing is, because I want you to go into this CCS exam with your boxing gloves on, ready to fight. So, the answer to this question happens to be on the cover page of the guidelines. Yes, the first page, second paragraph. These guidelines have been approved by the 4 organizations that make up the cooperating parties. And heads up, the cooperating parties for ICD-10-CM are also the cooperating parties for ICD-10-PCS. All right, on to the next question. Stephanie is being actively treated for a fractured femur. The seventh character would be. Now, I know exactly why, for those of you who got that code wrong, I know exactly why you got it wrong. And the reason that you got it wrong is because in your mind, how we're programmed, oh, Stephanie had a fracture. Stephanie's been actively treated for the fracture. Yes, that would be subsequent. Well, the guidelines say otherwise. And according to the guidelines, and I have the page numbers on here. So when I tell you it took me 6 hours to put this together, I really wanted to be intentional about what tonight looked like for you. Whenever I present, I'm always thinking about how I want the audience to experience the information that I'm providing. So, towards the end of this paragraph, while the patient may be seen by a new or different provider over the course of treatment for an injury, assignment of the seventh character is based on whether the patient is undergoing active treatment and not whether the provider is seeing the patient for the first time. So, in this particular situation, because Stephanie is being actively treated, it is not the subsequent, it is initial. When I first learned ICD 10 in 2010, I like saying that ICD 10 in 2010, I too thought it was slightly confusing, and I just had to remember that the initial is the active treatment situation. Now, let me just tell you, we were not alone. You are not alone. We were not alone. I did what do you call it? I queried the AHA coding clinic, and I know many of you have access to coding clinic because you are working as an inpatient coder, or you're working as a coder at a hospital. So you're using 3M. Um, so this happens to be a screen from 3M where I asked the system to give me every time there was an article on the seventh character. And if you notice, there were 17 articles that were the end result of my query. That means that the AHA, 17 different occasions, wrote articles on the seventh character. And this speaks to how confusing this was in the past. And so I would encourage you to, and I don't know how you would do this on your job, so don't get fired from your job, but find out how you could actually, or while you're coding, right? Look up some of these coding clinic articles. In previous versions of the CCS exam prep book, and I didn't see that as the case for this most recent version, but they have said in the past that it is recommended that you look at the last few years of coding clinic and CPT assistant prior to taking the exam. And so, if you have access to it, and the only other way to get access to 3M is for you to be in a program that is using it as a part of your academic journey, and you can get like the student version of it. But definitely some really golden, juicy details in Coding Clinic. Now, keep in mind that the seven character, the definitions of them in the fracture section actually change depending on if it's a closed fracture or the open fracture, which is using the Gastillo fracture classification. Just want to throw that out there. All right. Next question. What would the principal diagnoses be if a patient is admitted with atrial fibrillation due to underdosing of Coumadin because the patient could not afford their medication? And again, guys, I know you're sitting there thinking to yourself, man, oh man. But that's all right. The next time I give you an exam like this, you're going to be all on top of it because you're going to be like, I'm going to use my guidelines. I know the importance of reading the guidelines and being able to apply them. And you can't say, oh, I haven't coded before and all that jazz. You got the answers right in front of you, basically. So here are the rules. Underdosing refers to taking less of a, page 82, less of a medication than is prescribed by a provider or a manufacturer's instruction. Discontinuing the use of a prescribed medication on the patient's own initiative is classified as an underdosing. For underdosing, you are to assign codes from category T36 through T50. And I'm going to just scooch on down to the bottom. Codes for underdosing should never be assigned as principal or first listed codes. Let's just rewind back to this scenario. And this is what I saw many of you do. So, what would be the principal diagnoses? That is the $1 million question, because the patient is admitted with AFib due to the underdosing. Well, the rules state that underdosing cannot be principal. So then the principal diagnoses would be the atrial fibrillation. And I know some of you are sitting there going, aha, aha, aha. Learn those guidelines. You can't memorize all of them overnight, but you certainly can know that a rule exists, understand the rule. So on the day of any exam, you can apply the rule. All right. Coumadin must be very popular today. So a patient takes Coumadin as prescribed, and it is correctly administered. However, the patient develops hematuria due to Coumadin. The correct coding assignment for this case would be, and Let's look at some rules on page 81, same page as the last guideline we saw. So, when coding an adverse effect of a drug that has been correctly prescribed and properly administered, the appropriate code for the nature of the adverse effect. Now, let me just tell you something funny. This is how I remember it. When you have an adverse effect of a drug, what you're coding first was what had happened was. What had happened was that this patient was taking their medication properly, and what had happened was they got hematuria. That is the nature of the adverse effect, followed by the appropriate code for the adverse effect of the drug. And it talks about it should have a fifth or sixth character or whatever. So I don't know if this hit you just at this moment, but what did you literally just see? Adverse effect, T code goes second. Poisoning, T code goes first. Mm, mm, mm. All right, on to the next question. Oh, this was a juicy one. What would the principal diagnosis be if a patient had a non-STEMI 2 weeks ago and was readmitted with chest pain, found to have a new STEMI? And what did they do about it? They did a coronary angioplasty with a stent insertion. So, whoo, this was one, and I do look at how many people missed the question, and I'm like, okay, what was the thought process? But let's see the guideline. Let's see the guideline. All right, so subsequent acute myocardial infarction. A code from category I-22, subsequent ST elevation and non ST elevation, myocardial infarction, is to be used when a patient who has suffered a type 1 or unspecified AMI and has a new one within a 4-week time frame of the initial AMI. A code from I-22 must be used in conjunction with a code from I-21. Let me just pause for a second. I want to go back to the scenario. So, yes, our patient has had two STEMIs, one 2 weeks ago, and then now they're having another one. And what they're doing on this encounter is putting in a stent. However, according to the rules, um, you got to use that subsequent MI. And I think this is what I'm thinking because I do a lot of analyzing tests, answers, selections. I think some of you in your head said, well, the answer choice said acute MI and subsequent MI. And so it was acute, but I didn't think about the fact that they're both acute. We're in the 4-week time period. But 2 weeks ago, they had that other MI. They had another one which requires them to come back. That is the condition established after study. So here's something that just popped into my mind. On the real exam, there are going to be two questions, two answers that look correct. You have to use your critical thinking skills to figure out, okay, which one of these is the best answer choice. And in this particular case, it would be the subsequent MI. Okay. All right. Next. Oh, this broke my heart. This broke my heart. Secondary diabetes is blank caused by another condition or event. Guidelines, page 40. I'm just going to skip on down to the last sentence. Secondary diagnosis is always caused by another condition or event. This hurt my heart. This hurt my heart. Again, The goal of today is to not make anybody look bad. Nobody knows who got what on the exam. My goal is that you walk away scratching your head saying, "Ooh, that was me. Let me make some adjustments to what I'm doing on this exam." Okay? All right, next question. Grace, who is 81 and suffers from dementia, was admitted due to a fracture of the femur, pathological in nature. She suffers from metastatic bone cancer as a result of the uterine cancer, and on day 4, Grace died. What is the principal diagnosis? All right, here is the rule. Sequence as the principal diagnoses the condition which, after study, occasioned the admission to the hospital, even though the treatment may not have been carried out. So let's go back. Grace has dementia. We know that. Grace came in for a fracture because what do they want to do for the fracture? They want to treat the fracture. That is the condition that was the reason for the hospital stay. Many of you selected, and let me just see. Many of you selected metastatic cancer. Many of you, I would say probably half of you selected the metastatic cancer as opposed to the fracture. All right. But again, this is a learning experience that you're going to, again, you have the recordings, right? So you can most certainly go back and review, and review. All right. Let's keep going. I want to make sure I get through all of this tonight. So, Hillary, age 62, who suffers from diabetes type 1 and dementia, Alzheimer's type, was admitted from a long-term care facility with a stage 3 pressure ulcer of the right buttock area. Area was covered and surrounded by gangrene. Removal of the necrotic skin took place in surgery following the following day. Antibiotics were administered both orally and by ointment to the site. In addition, her diabetic medications were regularly administered, and on day 3, Hillary experienced an inferior wall MI and expired. So, there's a couple of things that I really want to call out on this scenario. And this is coming to mind right now because last week I assigned you guys I gave you 15, I think, inpatient records to review. One of them, which I am planning on us going over tonight if we have time. But you should be going through all of them and coding them in alphabetical order of the patient's last name. But what came to mind for me is that you're going to see all this jazz going on in these medical records. You have to, on the day of the CCS exam, not allow the noise to distract you and simply answer the question. So the question is, did Hillary have any comorbidities? If so, what are they? First things first, in order to answer this question, you got to know what a comorbidity is. We actually we actually talked about comorbidities, I believe, last week. And so as I was putting these questions in, I said, yes, they're going to know this, but let me find out. So one of the characteristics of an inpatient coder, a hospital coder in general, is to research. So there is a company called MD Clarity, so MD for physicians, and on their website, and because a lot of physicians, I don't know if you guys know this, a lot of physicians have gotten into this coding, clinical documentation improvement. So they're really learning these rules. Now, I said a lot, but not all of them. So let's see what these definitions say. I'm going to just skip down to number 2. Comorbidity. Comorbidity refers to the presence of one or more additional medical conditions or diseases in a patient who already has a primary diagnosis. Now, just for clarity purposes, you and I both know inpatient, the word is principal. That's why we're the coders. These additional conditions may or may not be related, I'm going to switch the word, to the principal diagnoses, but can impact the overall health and the treatment plan. Pause. Why? The mere fact that they have these conditions means that we may have to give them medications to keep those conditions stable, or we may have to do additional workup or whatever the case may be, right? So they qualify as a secondary diagnosis. So let me just continue. Comorbidities can affect the severity of the principal diagnoses, complicate treatment, and influence patient outcomes. However, not all comorbidities are considered MCCs. MCCs are a subset of comorbidities that have a significant impact on resource utilization and reimbursement rates. So let me just bring some clarity to this. Last week, I talked about the fact that for the CCS exam, the version of the coding manual that you must have for diagnoses is that hospital version. And um, in the tabular list, the manual tells you if a diagnosis is a CC or an MCC. And I happen to have a screenshot of a page later tonight. But so you don't have to know them. The tabular list is going to tell you if something is a CC or MCC. But just to summarize what we just reviewed, um, comorbidity is something they walk in the door with, something they already have. And guys, remember I said if you see something you don't know what it means, look it up, make it make sense to you so that you can answer the question. Okay. So back to the question. So the question was, did Hillary have any comorbidities? Things that Hillary walked in the door with, right? And that was um the dementia, and the diabetes type 1, right? Those were the comorbidities. The principal diagnosis is going to be that that stage 3 pressure ulcer. Okay, I'm getting tongue tied. All right, so that's that. We'll come back to the word complication on a different question just because I want to make sure we get through all of this. All right, so Fred has diabetes type 1, dementia, admitted from home with the stage 3 pressure ulcer, right buttock area. The area was covered and surrounded by gangrene. Removal of the necrotic tissue took place following day. Antibiotics were administered both orally and ointment. And I know you were thinking, man, these two patients look the same. A little different. Fred had a stroke and expired. But now the question is, does Fred have any complications? So there's one thing that comes to mind. Oh, this is a good night. If I must say so myself, this is a good night. Um, on the day of the exam, you're gonna see one question at a time, like you're seeing now, um, for your exams. And as each question hits the screen, it could be the same type of scenario, but a different question that's being asked. And in this particular case, the question is, what is the complication? Let's go back to the research and read the definition for complication. This is an additional medical problem, condition that arises during the patient's course of illness or treatment. It is an unexpected event or occurrence that may prolong the patient's hospital stay, require additional treatment, or increase the level of care needed. Complications can range from minor issues, blah, blah, blah. All right, so um, I'm just going to stop there. The question was, What type of complications did did Fred have, right? And so the complication, if you go back, on day 5, Fred experienced a stroke. Fred didn't have a stroke when he walked in the door. Fred walked in the door with diabetes, dementia, a pressure ulcer, right? Fred had that stroke, and that's what caused Fred to pass. All right. Let's do another question before we take another break. Melania, and I'm taking these breaks just to allow you time to catch up on your notes. First of all, give me a break from talking because I'm covering a lot of information. Melania had a left mastectomy in October for breast carcinoma stage 2. Currently, she is receiving chemotherapy once per week. Let me just pause and say something. You know that code Z5111, whatever that code is, admission for chemotherapy? That only goes onto the chart if that is the reason for the encounter, a reason for the admission. It's not just thrown on there, okay? So she also suffers from anxiety as a result of the disease. Today, say it with me. Today, Melania is being admitted for her anxiety. What is the principal diagnosis? The principal diagnosis is the condition established after study to be chiefly responsible, and in this particular case, it is the anxiety. It is not. Let me make it make sense because some of you selected history of breast cancer as the principal, um, or some of you said breast cancer. The insurance company already knows the patient has breast cancer. Why is the patient there today? The patient came because they have anxiety as a result of the disease. So the principle is the anxiety. You can list the cancer as a secondary diagnosis, answer the question, what is the principle? And the principle is anxiety. All right. Fred. Why do I feel like we just did Fred? Yeah, we just did Fred. So I must have captured Fred twice. So anyway, yeah, we know about Fred. Fred had complications, right? So yeah, here's that. Okay, Bernie. Um And in case you're wondering, does she come up with this stuff while she's watching the news? Yeah, not necessarily for people's conditions, but just names. Yeah, okay. Bernie, age 76, has suffered from Parkinson's disease for 5 years. Insurance company already knows that. Okay. He wears a hearing aid due to his unilateral hearing loss. Insurance company already knows that. They want to know, why is the patient here today? Coming in to the ER today, he complains of a migraine headache. After workup, a 7-day stay in the hospital, he was diagnosed with a ruptured berry aneurysm. What is the principle? It is not the migraine headache. It is that aneurysm. And I think only 1 or 2 people got this question wrong. But again, what I did for tonight, every question that was missed, I'm talking about it. All right. So after study, and they say after workup, study, same thing. Okay, so you got that. Next up, fractures not documented as displaced or non-displaced are coded as woo guidelines, page 77. A fracture not indicated as open or closed should be coded to closed. A fracture not indicated whether displaced or non-displaced should be coded to displaced. Guys, I just want to know for myself, do you have those guidelines? Type in the chat for me. Do you have those guidelines printed out? Are you reviewing them? And if you are, then what happened? I need to know what happened. All right. A patient is diagnosed with hypertension and chronic kidney disease. Which code category should be used to code the principal diagnoses for this encounter? So, for this question, I am going to show you the guideline. Guidelines state assign codes from category I-12, hypertensive chronic kidney disease, when both hypertension and condition classifiable to N18 are present. All right. So I-12 goes first, and then the N18. What does it say here? The appropriate code from category N18 should be used as a secondary diagnosis. Again, guys, the stuff is like right there in front of you. And then I wanted to show you the tabular list. The tabular list is telling you use additional code from the N18 category. So as you take this next 10-minute break, I really want you to think about, and I'm going to ask you at the end of the night, I want you to think about and reflect on what happened during the exam. You got to figure that out. Let's take this 10-minute break. All right, we are back and on to the next question. So, this topic was actually something that I would say was newly introduced to you, and I expected that some of you would get the question incorrect. Um, but also I just wanted to see, like, did it stick? And so hopefully tonight will bring further clarity. All right. So, which of the following is known to impact the MSDRG? So, the answers were like the symptoms, the patient age, the admission date, or the severity of illness. So, I want to introduce you to a resource that you do have access to. You may not know you have access to, but I'm willing to bet that you will, after tonight's class, you will find it. But this is the MSDRG definitions manual. It is on the cms.gov website. And on my slide, I say it's version 41, but actually, as you can see from the screen capture, we are now on version 42. So, a couple of things I want you to see in this table of contents. And I think the very first thing is you should read that article that says defining the MSDRG groups and design and development of the DRG. You should read that because it really has some really powerful information. Speaking of, in that first option, it tells us that each MSDRG is defined by a particular set of patient attributes. So, principal diagnoses, secondary diagnoses, specific. Why do they keep saying specific? That's because some secondary diagnoses do not impact the MSDRG because they are not a CC or an MCC. I've said that so many times. I feel like it's gonna be sticking. All right. So procedures, sex, and discharge status. So they didn't mention admission date, admission diagnoses. They didn't mention the patient's age. They didn't mention symptoms. And so the best answer was severity of illness because we're talking about Medicare severity diagnoses related groups. This is a question that you could see worded, multiple ways. And so I'm going to make sure that you see them those multiple ways. Okay. Also, I will tell you that I don't believe in teaching towards the exam. I believe in covering the content so that you can apply it on the day of the exam and beyond. Keeping in mind, your organization is going to have rules, all the things, but I don't want to focus on solely the exam. The last sentence I want to call out is it says, this chapter is organized around the 25 major diagnostic categories. You learned about that last week as well. All right, so moving on to the next question. When reviewing records in order to code them in an inpatient setting, coders usually start with reviewing the what? Now, I know you guys know last week, and this is what I'm wondering, and this is a question for you. This is personal. Are you taking notes? Do you understand the notes that you took? Or did you just completely tap out? Because remember last week I showed you my buddy Jennifer LeMay did a inpatient coding review. And then I did a separate one, and the goal was you find one that you like better, works for you. Everybody is different. But we talked about this. So you got to ask yourself, did you not remember what really happened? All right. So when reviewing the record states, we start with So here's a little diagram that I put together about the inpatient record review and source documents. I threw in the word source documents because on the CCS exam, and let me just be very clear about something. I need to set the record straight. Nobody has the answers to the exam. What we have is the content outline for what you are expected to know. What we have is the fact that we functioned as inpatient coders, auditors, managers, whatever, and we know things, but nobody has the answers, okay? But one area that is very clear in review guides and all of that is that the inpatient coding process starts with the discharge summary. I know many of you have not coded inpatient, one or two of you haven't coded at all. So during one of the domain reviews, I will go over really quickly the different forms that are in the medical record. But again, if you are personally discovering some deficiencies that you have that you need to take care of in order to be prepared for the exam, that's a personal thing that you really want to have on your list and that you figure that thing out. Okay. Because a coding program could be a year long. I can't cover a year long worth of material in a review class. And I know you're like, why does she keep saying that? I keep saying that because I don't want you to be feeling like, well, she should be doing this and she should be doing that. This is a review. This is not introduction to coding. All right, so we start with the discharge summary and then we go to the H&P. Let me just pause. I want you to just get this, get this. We start with the end, which is the discharge summary. And then we go to the beginning, which is the H&P. Now, I threw in orders because a lot of times orders will help you connect the missing dots. Also, in the orders, you should see that there was an order for this inpatient hospital stay. I don't know if on the CCS exam that they're going to have orders in the medical scenario that you have to code at the end of the exam, but it's in a real world record. All right, so then after that, ancillary reports, test results. Keeping in mind, you cannot code from abnormal findings. The doctor has to indicate the clinical significance per the guidelines. But after that, operative reports, because you can pick up significant procedures for ICD-10 PCS. You can look at consultations, which will help you get additional diagnoses or confirmed diagnoses, progress notes, nutritional assessments, and then other clinical documentation. But to answer the question was about where do you begin? And we generally start with the end, which is the discharge summary. All right, next question. Patient is admitted for chemotherapy for metastatic breast cancer to the liver. At this stage, as you're reading the note, visualize what is happening. Patient is admitted for chemotherapy for metastatic brain cancer to the liver. The patient had a mastectomy 4 months ago, and this is her sixth round of chemotherapy. What is the principal diagnosis? And here's the rule. If the patient is admitted for chemo, immuno, radiation therapy, that is the principal diagnosis. The malignancy is going to be listed after that. And I think one or two of you said metastatic liver cancer. Somebody said breast cancer. And again, here, this is not applying the guidelines. You had the guidelines in front of you during this exam. Ask yourself, did I not go to the guideline? Did I not understand the guideline? Did I not correctly apply the guideline? Find out what your personal why is. All right, page 34. Next up, when coding an adverse effect of a drug that has been correctly prescribed and administered, the principal diagnosis is whoa, 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 whoa. We know this answer. Back to page 81. When you're coding an adverse effect of a drug, correctly prescribed, properly administered, the nature of the adverse effect goes first, followed by the T code. Poisoning, T code goes first. Adverse effect, T code goes second. All right. A patient is admitted for spotting. She was diagnosed and treated for a miscarriage with sepsis. In the coding world, I want to just call out that the coding world uses, or the medical world, I can't remember. Anyway, if the patient has a miscarriage, that is known as a spontaneous abortion. That's not meaning like the patient went to the abortion clinic with the intent of terminating the pregnancy. This was that the body expelled the fetus. Okay. All right. So here, I want to show you alphabetical index. Main term sepsis, under sepsis, following abortion. And again, abortion is meaning that the fetus has aborted from the body. I think that what I saw, and I don't have that particular portion of my notes in front of me. I think most of you got this correct. Maybe one of you used sepsis would be the principle, but it would be spontaneous abortion with sepsis. That would actually be the correct. Okay. So maybe it just was a misunderstanding. 75-year-old male is admitted with fever, lethargy, hypotension, tachycardia, oliguria, and an elevated WBC. The patient has more than 100,000 organisms of E. coli per cc of urine, and the attending physician documents urosepsis. What do we do? All right. So here's from the guidelines, page 22. Urosepsis is a non-specific term. It is not meant to be considered synonymous with sepsis if it has no default code in the alphabetical index. And if the provider uses that word, we have to query. That's one of the domains for the CCS, which we will be covering. All right. Next up, a patient was admitted with lethargy, congestive heart failure, pleural effusion. The patient underwent treatment with diuretics for CHF, which is cleared. The pleural effusion required a thoracentesis to determine the cause. At the time of discharge, the effusion was decreased but not resolved. Which of the following conditions would not be coded? Now, I don't know if on the CCS exam, they're going to have things like accept, not, because remember, nobody has the answers to the CCS exam. I took the CCS exam in 2006, so that's almost 20 years ago. Um, and so I'm just trying to prepare you to expect the unexpected. All right. So, which of the following would not be coded? And here is what I saw quite frequently was that you guys answered that you would not code the congestive heart failure and the pleural effusion. Um, the question is asking what would not be coded. The correct answer is lethargy. And I like to research different medical websites. Cleveland Clinic. Lethargy comes from the two ancient Greek words lethe, meaning forgetful, argos, meaning idle, as those two terms describe someone who's lethargic, moves slowly, or is difficult to rouse and has trouble thinking, concentrating, remembering. But the question asked you, let me go back to the question, which would not be coded. All right. Next up, 60-year-old male is admitted with a history of prostate cancer and mental confusion. The patient completed radiation therapy 3 years ago. Is status post radical resection of the prostate. A CT scan of the brain during the current admission reveals, I should say metastasis, but it says metastatic. Which of the following is correct coding and sequencing for the hospital stay? So, on the day of the exam, you have to be thinking through what's going on and then answering the question. Now, one strategy, and this is just something I want to just call out. One strategy you could use is look at the question first, meaning, what do they want me to do? Which of the following is correct coding and sequencing for the current hospital stay, right? So look at the question and then go back and read the scenario so that you could make a decision. So we know they have a history of prostate cancer and mental confusion. But why are they there today? They had the radiation stuff 3 years ago, radical resection. But what has happened is they had a CT scan of the brain, which reveals that it's spread. Um, I put this question in here because several of you said that the mental confusion, like you said that should be first. No, 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 no. Okay. What do the guidelines state? The condition established after study, page 106. After study, it was determined that the patient has this metastatic brain cancer. So, metastatic brain cancer would be first. And then, second, you would list a history of carcinoma of the prostate. Now, I didn't add this on to the slides as a guideline to call out, but now I'm thinking I might should have. But there's this rule that states if there is no evidence that the patient still has the cancer, it has been excised, all of that, it's coded as a history of. So that's another guideline that would be called out. Also, admission for radiation therapy, that is not what's going on here, guys. So make sure you're taking your time to read the scenario. I know you're thinking, I got 4 hours to answer these questions. Your 4 hour and the amount of time that you spend on questions can be sped up if you know the rules, know where they are, and can apply them. Food for thought. All right. Which of the following does not represent a characteristic of combination codes? Woo, I was beside myself when I was looking at this. So, just so you guys know, on the days that you're doing exams, I'm literally working on what the next exam is going to be based on what we talked about, all the things, right? And then I'm actually refreshing my screen to see, when you submit. And as soon as somebody submits, I go to look at the questions and the responses. But anyway, guys, this is from the very beginning of the guideline. A combination code is blah, 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 blah. So here's where I think the disconnect happened. The question asks, which of the following, let me go back, which of the following does not represent? Whenever you see the word does not, you got to find out what does. Yeah, that's it right there. All right. So let's keep going. A patient is admitted with fever, cough, and shortness of breath. After evaluation, the discharge summary states possible pneumonia. How is it coded? Guidelines, page 107. Uncertain diagnoses. If the diagnosis documented at the time of discharge is qualified as probable, suspected, likely, questionable, possible, or still to be ruled out, compatible with, consistent with, or other terms indicating uncertainty, you code the condition as though it exists. And so the pneumonia is the principal diagnoses. But let me just call out something else that is worthwhile mentioning. Fever, cough, shortness of breath are signs and symptoms of pneumonia. Signs and symptoms that are integral to a disease process are not coded separately. All right, let's go. It's almost time for another break. The definition of other diagnoses is interpreted as additional conditions that affect the patient care in terms of requiring any of the following except. And you guys will tell me if the words without, except, not, if that's what was throwing you off. And I think today you should walk away with, oh, I'm not going to let that throw me off. So, page 109 in the guidelines talks about other diagnoses. And again, we started this review on January 27th. It is my expectation that by now you have read through all of the guidelines. Only you know what you have and have not done. All right. So um, it said which of the following except, and except the answer that was the correct answer was increased reimbursement. That is not listed as one of these 5 options. All right. The condition established, I know the guidelines so much, it just rattles off my tongue. Let me read the question properly. The condition, after study, is established as chiefly responsible for occasioning the admission of the patient to the hospital is a principal diagnoses, straight from the guidelines. Which of the following would be classified with ICD-10-CM as an external cause code? Now, when I looked at the answer that one of you selected adenocarcinoma as the answer. And the question said, which of the following will be classified as an external cause code? That right there just let me know that you didn't go to the guideline to look at this. So here are the guidelines, page 86. External causes should not be sequenced as first listed or principal. And they provide data for injury research and evaluation of injury prevention strategies. And they tell us the how it happened, the cause, the intent, blah, 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 blah. Again, if you have not read these guidelines through and through, you have to. If you're finding that you read them and during this exam, you looked at it and you still got it wrong, you have to ask yourself what happened. All right, next question. Patient is admitted for treatment of dehydration secondary to chemotherapy for primary liver cancer. Which of the following should be sequenced as principal diagnoses? Admitted for treatment of dehydration secondary to chemotherapy. And I hope I grabbed the right guideline. So this guideline that I have here says management of dehydration due to malignancy. I definitely grabbed the wrong guideline. So let me go and what page is this on? Page 33. I definitely grabbed the wrong guideline. So let's go over to page 33 and hopefully you guys are seeing this. Okay, 1 second. So admitted for treatment of dehydration secondary to chemotherapy. Oh, that might be the right guideline. I was thinking of something else. Clearly was. All right. So page 33. When the admission encounter is for management of dehydration due to the malignancy and only the dehydration is being treated, the dehydration is sequenced first. Several of you, maybe one of you, listed chemotherapy first, but the dehydration goes first. And I have my guidelines uh in front of me because I want to make sure that I don't tell you anything wrong. And I'm pausing for a second because I'm still scrolling through the guidelines because I just want to make sure that I'm not giving you incorrect information. Nobody is perfect, right? But I just try to make sure that I'm not confusing you. Yeah, I'm confident in that guideline selection. All right, next up. Oh shoot. I went. All right. A patient is admitted for nausea, vomiting, and abdominal pain. The physician documents on the discharge summary acute cholecystitis, nausea, vomiting, abdominal pain. Which of the following would be the correct sequencing? So I talked about this before, but I want to just reintroduce a resource that coders use during the inpatient coding process, which is the Merck manual. We actually, I don't know if you guys remember, but we talked about the fact that many of you are encoder dependent. Remember that conversation very early on? Well, the Merck manual is inside of 3M, but you can go and get the online version, not the one for professionals, but the one, not the one for patients, the one for professionals. I personally, call me old school, I got a physical copy of it, but you can't use the internet or the Merck manual during the exam, but you can certainly use it while you're practicing. Acute cholecystitis is inflammation of the gallbladder that develops over hours, usually because a gallstone obstructs the cystic duct. Symptoms include right upper quadrant pain and tenderness, sometimes accompanied by fever, chills, nausea, and vomiting. Let's just pause for a second. Patient was admitted with nausea, vomiting, and abdominal pain. So the question asks, which of the following would be correct coding and sequencing for this case? So many of you said acute cholecystitis would be first, followed by nausea, vomiting, and abdominal pain. So remember, signs and symptoms that are integral to a disease process are not coded separately. I know I keep saying this, but I just want to let you know that I am going to honor the promise that I made to you. Was I'm going to have one of our days where I'm going to do a review, a brief, a very brief review of anatomy, physiology, by body system, along with disease process. I have a good friend of mine who is a nurse, and we're going to tag team that presentation. I'm going to present the system and the organs, and then she's going to talk about diseases. And she is such an amazing nurse. But what I hope you walk away with is, and I'm in the process of preparing a handout for you, but I hope you walk away with, okay, signs and symptoms that are integral to a disease process are not coded separately. All right. Okay, so those signs and symptoms shouldn't have been coded. Patient is admitted with dysuria due to a severe urinary tract infection. Which diagnosis should be reported? Guys, the concept is the same here, but I got to give you some research. So I went to my Mayo Clinic. I like the Mayo Clinic. UTI, infection of any part of the urinary system. Urinary system include the kidneys, two of them, ureters, two of them, bladder, one, urethra, one. Most infections involve the lower urinary tract, the bladder, and the urethra. UTIs don't always cause symptoms, but when they do, they may include, and look at what they said, that dysuria is there. Dysuria is difficulty pain with urination. I also thought that this was cool to see um, the different types of urinary tract infection and the actual symptoms. I thought, I'm a nerd. I thought this was really cool because it tells you if it's the kidney, this is what normally happens. If it's the bladder, this is what normally happens. If it's the urethra, this is what normally happens. And the reason why I'm pushing this understanding disease process so bad is because remember how we talked about many of you are working at organizations, two of you are inpatient coders. You don't query the provider. The CDI specialist does that. But for purposes of this CCS exam, you got to know how to query. And if you don't understand the disease process, how can you how can you query the provider? All right, let's take another little break and we'll start now. All right, everybody, we are back. Excuse me. All right, so we're going on to our next scenario, and luckily, we only got about 10 more questions to cover. All right, so the patient is admitted with pneumonia. The patient is HIV positive, but has never had any opportunistic infections. Let me just pause for a second. If you don't know what an opportunistic infection is, that would be something that while you're in this preparing for the exam phase, that you would go back and re-review. The doctor notes as the final diagnoses pneumocystis carinii, pneumonia, AIDS, and thrush. What would be the principal diagnoses? Many of you said the pulmonary candidiasis. That would be first. So, I got a couple of things that I want to discuss. Page 20, patients with known diagnoses of HIV should be coded to B20. Once the patient has, oh, let me back up. Patients with any known prior diagnoses of HIV should be HIV related illness should be B20. The illness is that opportunistic infection. Once the patient has developed an illness, they should always be B20. So basically, they should not be going back B20, Z21, R75. Now, I know you're probably wondering, okay, I don't even know which one of these I don't even know what you mean by opportunistic infection, HIV related condition. So a couple of things, many websites. I found on the VA website, I was just Googling, they provide a list. Um, but the other thing that I thought was worthwhile for me to show you, and so this is the screen on the right, and I know that some of you don't have your coding manuals yet, but I brought this picture today for a couple of reasons. Number one, you see next to the right of B58.9 toxoplasmosis, that is an HIV related condition. How do I know? It has the little symbol HIV next to it. Then also to the right of it, it says CC. So remember, I told you that the tabular list will let you know if something is a CC or MCC. Now you are getting it in living color. The other thing that I wanted to call out here is B59. It says HIV, that's is right. It has MCC and then HCC. And for this exam, I don't think that you need to know anything about HCCs. So um, there's that. Um, what else did I want to show you? Oh, you notice how underneath code B60.0, it says AHA 2020 fourth quarter 5 through 6. That is referring you to a AHA, American Hospital Association, coding clinic article from 2020 fourth quarter, pages 5 and 6. So I said this before, but I want to say it again. It's recommended that you look at the last few years of coding clinic articles. And the articles come out, quite frequently. I think it's escaping me if it's monthly or quarterly. I think it's quarterly. Yeah, it's quarterly. It said fourth quarter, right? There was recently an article that came out on the new obesity codes for 2025. And I actually needed that article because I think I might have told you guys that today in 2025, half of my life is spent as a keynote speaker. I also do leadership coaching and leadership retreats and workshops. But the other half of my life is provider education. And so I needed some additional information regarding those new obesity codes, the class 1, 2, and 3. And so Coding Clinic came up with an article that allowed me to then provide education for the physicians, providers. So I wanted to point that out. When you get your manuals, you will be able to go and see these. And I just want to reiterate, for the CCS exam, after May 1st, 2025, you will need the 2025 edition, but also for the CCS exam, you need the hospital version. Remember last week how I was showing you I had the physician version up on the screen and how we didn't see this in the tabular? This is why you need this, because they could ask you a question on the exam like, which of the diagnoses impacts the DRG? Well, the first thing you have to do is figure out what's principal. And so in our particular case, let me go back to the scenario. The B20 would be the principal diagnoses, right? And then I'm going back the wrong way. And then the pneumocystis carinii, which is the code B59, that is a MCC, so it would impact the MS-DRG. So I'm hoping that today, and I want you to know, I have dreams about when I am speaking, when I am teaching a review class. I have dreams about what I want you to experience, and so I am going to be very interested in hearing what your thoughts are after we get to the end. All right, so I'm going to move on to the next question. All right, my throat is just so dry now. All right. ICD-10 official convention located in the alphabetical index has a highlighted main term to help the coder find conditions identified in the patient medical record. And did I even put something for here? Because I got confused. Oh, I did. I did. So a few weeks ago, I said to you all, if you know you personally need a refresher on the basic steps of coding, I recommended that you get the AHA ICD-10-CM PCS handbook. I recommended that you get that because if you don't know the basics, you can't or don't know or don't remember. You can't say, I don't know, I don't remember, I never coded before. You can't say those things. If you're going to take the CCS, you got to up your game. So in this particular book, it says, I think it's chapter 1, a clear, and this resource is also with inside of 3M. Anyway, a clear understanding of the format of the alphabetical index is a prerequisite for accurate coding. Mm. Understanding the indentation pattern, I can't hardly see, of the entries is a very important part of learning how to use the index. Then they tell you a variety of vendors provide printed versions, others have computer programs, but the format may not be consistent. The PDF version of the index represents each indentation by a hyphen, which that's what you're using now until you get your physical book. However, the following pattern is used by several code book publishers. This is getting to the answer. Main terms are to the left. They are printed in bold type and begin with a capital letter. So that question was like uber basic. And if you got it wrong, that tells me, that tells you that you need to go back to the basics and clean up your knowledge, understanding, comprehension. A pre-existing condition that is present on admission and may lead to increased resource use. Pre-existing condition. Same type of question, just reworded differently. It's a comorbidity. It is a pre-existing condition. I know some of you are over there like, oh, trust, I will not get that question wrong again. All right. Whew, we're almost done with this part of our evening. 50-year-old male with a history of lung cancer is admitted to the hospital with ataxia and syncope and a fractured arm as a result of falling. The patient undergoes a closed reduction of fracture in the ED, in addition to undergoing a complete workup for metastatic carcinoma of the brain. Now, keep in mind, the patient was admitted to the hospital. We need to know why. The patient is found to have metastatic carcinoma of the lung and brain and undergoes radiation therapy to the brain while admitted as an inpatient. Pause for station identification. You would not put one of them Z51 situations on here as a secondary or principal. That was not the reason why that patient was here today. So, which of the following would be the principal diagnoses? When the patient is admitted because of a primary neoplasm with metastasis is directed at the secondary site is the principal, even though the primary is still there. And that's page 33. Let me just make sure I got the right guideline. Oh, yeah, metastatic carcinoma of the brain. The focus was they have metastatic carcinoma of the lung to the brain. So it went from the lung to the brain. Brain is secondary. So yes, that guideline applies. Now, I know you're like, "Oh my gosh, you're just talking about these guidelines with ease." So here's the funny thing, and they say everything happens for a reason. So I had a book that I wrote and published called ICD-10-CM coding concepts. And my publisher has literally been saying all year, "Where's the 2025 version? Where's the 2025 version?" I'm like, "Okay, I have the version. I just need to check the answer key." And she was like, now she don't even know anything about coding. She was like, "You need to get your 2025 version out." So this was this was my this was my wake up call that I needed to go ahead and get my 2025 version published. All right, so on to the next question. When assigning ICD-10-CM codes for outpatient services, uncertain diagnoses are. So let me just pause for a second to call out two things. Now we're talking about outpatient, but we're also talking about uncertain diagnoses, and the rules are different. This is page 112. Do not code diagnoses as probable, suspected, questionable. I think it is, it could be, it looks like. You don't code those in outpatient. So I really hope that you walk away tonight saying, "Oh, I've got to get into those guidelines. I've got to do it." If the same condition is described as both acute and chronic and separate sub entries exist, at the same indention level, code both and sequence the acute code. And the guidelines say to sequence the acute subacute code first, straight from the guidelines. All right. Next one. A patient was admitted to the hospital with disturbed coordination and weakness of the extremities to rule out multiple sclerosis. Electromyography and other tests were performed, but at discharge, multiple sclerosis had not been positively confirmed, nor had it been ruled out. The physician documented the following diagnoses: rule out MS, multiple or muscular incoordination, muscular weakness, fatigue. Principal diagnoses. This is inpatient. So you can code uncertain diagnoses. Now, I will tell you that some hospitals have a policy that for MS, you don't code it unless it's confirmed. But per the guidelines, you can code it. Remember, on the day of the test, this is not about what you do at your job. There is no way a HEMA can go to every job in the world and ask you what you do and then adjust the questions accordingly. So they have to provide the test questions based on guidelines. Okay. All right. Next. Following a fall at work in which his head hit machinery, a patient was admitted conscious and observed for neurological problems and other injuries. The patient had returned to his pre-existing conscious level upon admission, complaining of a headache, especially moving on his head. Total length of LOC is unknown. No other injuries were identified by X-ray or CT. Um, Patient was discharged home the next day with um, with the diagnosis of concussion, prolonged unconsciousness. Now, I think only one or two of you got this wrong. And I'm going to be honest, what you did was coded like you coded the external cause as the first listed code. It actually what was the principle. Remember, external causes should never be principal or first listed. So, guys, I hope that after tonight, you'll go back through the questions you got wrong because you should be able to see them now and just really do some reflection on what had happened. All right. Next patient. Patient was admitted following an attempted suicide. The patient ingested an unknown amount of diazepam. During inpatient hospitalization, the patient was treated with gastric lavage. The attending physician documented the final diagnoses. Um, Depression with anxiety, attempted suicide by ingestion of Valium and hypotension. So I feel like we we've been here before. I feel like we've been here before, right? So um attempted suicide, unknown amount of diazepam. So they were not taking it properly. So yeah. What do the guidelines state? This is a poisoning. And in the guidelines, page 81, examples of poisoning include and they give you all of these things. If an overdose of a drug was intentionally taken or administered. Okay? So, yeah. All right, guys. We're almost done with this part of our night. The patient spontaneously delivered live-born twins in her third trimester. Pregnancy, 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 pregnancy was complicated by eclampsia through her third trimester. The patient's postpartum course was unremarkable and the blood pressure returned to normal soon after delivery. What is the principal diagnosis? Many of you said um, eclampsia here, okay? That is not, 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 not. And let me see if I can remember. Um, I had these screenshots of the tabular list for a reason, but I can't remember why I did it. So let me go to the other one. Multiple gestation. Code also any complications specific to the multiple gestation. The twin pregnancy would go first. Okay. All right. We're almost done with this part. I know many of you are happy. Patient was admitted to the hospital following an automobile accident, which he suffered 5 closed fractured ribs on the right, which resulted in a lung laceration. During the hospitalization, the patient complained of chest pain. EKG was normal. Patient also complained of headaches. CT of the brain was negative. Chest tube was inserted. The next day, a thoracotomy was performed to close the laceration. What is the principal diagnosis? Many of you said the laceration of the lung. Um, if you're going to code that as coded, I would only code it as a secondary diagnosis. The fractures were clearly the reason why that person was there. Now some of you will say, well, they did a chest tube for the drainage and a thoracotomy was performed to close the laceration. Um, After study, the reason for the admission is the fractures. Whew. So on Wednesday, our entire time on will be spent on domain number one. But we are now going to take another break, and I want you to get out that first medical record that that we talked about, and um, we're going to start there. And let me just serve notice: you need to code all 15 of them. We will talk about the first one tonight. We'll go over it together. But you need to keep coding them. Okay, code all of them. All right, let's take our next break. It's a long day today, guys. Long day.